Hello, and welcome to the International Society of Liquid Biopsies webinar in collaboration with OncoHost on addressing unmet needs for predictive IO biomarkers. The agenda today is having Dr. Gandara discuss the unmet need for predictive biomarkers for immunotherapy. Dr. Ofer Sharon will discuss Prophet, a plasma proteomic predictive biomarker for immunotherapy, and Dr. David Carbone to discuss the validation and clinical utility associated with Prophet. For the Q&A today, you'll notice at the bottom of the screen, there is a Q&A box. Please put your questions in this box, not in the chat box. They will be addressed at the end of the webinar after all speakers have presented. And also, if you could address a question to one of the specific speakers, that would be helpful. And our speakers, again, Dr. David Carbone, Dr. Ofer Sharon, and Dr. David Gandara. So I would like to do an introduction first for Dr. Gandara. Dr. David Gandara is a professor of medicine and co-director of the Center for Experimental Therapeutics in Cancer and senior advisor to the director of the University of California, Davis Comprehensive Cancer Center. Dr. Gandara is the Chief Medical Officer of the International Society of Liquid Biopsy, the ISLB. Thanks for hosting. Prior to his present roles, Professor Gandara was president of the International Association for Study of Lung Cancer, ISLB, as well as treasurer and BOD member for the American Society of Clinical Oncology, or ASCO. I hand it over to you, Dr. Gandara.
Thank you, Chris. It's my pleasure to participate in this webinar and represent also ISLB. These are my disclosures. And as Chris said, my role tonight is to talk about the unmet need for better predictive biomarkers for immunotherapy. As you can see in this slide, and this is ever changing, now checkpoint immunotherapy is being used throughout the cancer care continuum in non-small cell lung cancer from stage 1 to stage 4. And you can see the various settings, neoadjuvant and adjuvant therapy, consolidation immunotherapy after chemotherapy and radiation in stage 3, and in stage 4 in a variety of settings. So the question is, what is the role of predictive biomarkers in therapeutic decision-making, and how do practicing physicians select one therapy or the other? And we'll focus on stage 4 disease. First, though, non-small cell lung cancer is well suited for precision medicine, that is individualizing therapy. And this is true both for targeted therapies and immunotherapy. As shown on the left, of course, we're all very familiar with the growing number of oncogenes that we want to test for and that are actionable with targeted therapies. But on the right, and this is from TCGA, this is maybe a different version from what you've seen because it is not only quantitative for tumor mutational burden, showing non-small cell lung cancer here at the end, both adenocarcinoma in orange and squamous cell lung cancer in purple, that they are quantitatively very high in terms of tumor mutational burden, but as shown in the circles, also the types of mutations qualitatively position them well to be sensitive to immunotherapy. These are the C2A transversions, which are highly neoantigenic. And you can see these are very common in both adenocarcinoma and squamous cell. And lastly, in squamous cell, that TMB quantitatively is rather homogeneously high. This is my own collection of all the first-line immunotherapy trials in non-small cell lung cancer, and I show them not to dwell on individual studies, but rather to say that they are quite diverse in terms of the sorts of therapies, whether it's monotherapy or checkpoints in combination with chemotherapy, or in combination with each other, or including bevacizumab, whether a biomarker selection was used, what the histology was, if it was all comers or squamous or non-squamous, and the primary endpoints. But if you look at all of them together, you will see that almost all were positive for the primary endpoint. Only 2 negative studies shown here. So this means practicing oncologists have a wide range of trials to choose from. This is an algorithm which was originally proposed by Solange Peters, president of ESMO, and I have updated it, showing that an oncologist usually starts by testing for driver oncogenes. If they are present and they are used first line, they would use targeted therapy, and otherwise, perhaps they divide by PD-L1 very high, that is 50% or greater, or lower or even negative, and they choose a regimen, some of which are shown here. Well, how do the biomarkers fit in here? On the left, this is a very nice diagram showing that by comparison to oncogene drivers, for immunotherapy, we have a wide array of different potential biomarkers related to tumor neoantigenicity, the microenvironment, the host environment, or tumor suppressor markers. Now, the ones, of course, that we use most commonly are TMB and PD-L1. And you can see also, though, as shown on the right, that we have newer biomarkers which incorporate more complex genomic signatures. In this case, I show a proteomic signature, Prof, which you'll hear more about, which can individualize patients into a high probability of benefit or a lower probability. We also have some genomic biomarkers, which I will not discuss further in this brief presentation. For PD-L1, this is an old slide, but it's very informative. It shows that regardless of the tumor type, regardless of the checkpoint inhibitor, regardless of the PD-L1 assay that was used, if a patient has a cancer which is PD-L1 positive, they have a higher chance of response compared to negative. And yet for non-small cell lung cancer, we don't even use the same PD-L1 scoring system that we use for most other cancers. We concentrate on TPS, that is the tumor content, as shown on the left here, by comparison to CPS, which incorporates the immune infiltrating lymphocytes, which is used for most other tumor types. Despite this difference, as you can see here, PD-L1 high, that is 50% or greater, is highly predictive of benefit for response and for survival. This is about a third of patients. But as you can see on the left, there are always patients with PD-L1 TPS of less than 1% that seem to benefit either from monotherapy or shown here, combination therapy. And we also know that there is a histology difference. These are the original second-line trials for nivolumab, and as you can see in the top in the study 017, there is no relationship of survival in squamous cell lung cancer by PD-L1 expression, where there is a growing, increasing association in PD-L1 as it increases in score for non-squamous. Also, in patients who have PD-L1 0, less than 1%, you can see there seems to be a benefit in these combination studies with chemotherapy on the right and on the left in the nivolumab ipilimumab trial, leading some to pick this sort of regimen like Checkmate 227 for those patients with absent PD-L1 score. So PD-L1 is not a bad biomarker, it's an incomplete biomarker. It doesn't tell us the whole story. Part of the rest of the story, of course, is represented by tumor mutational burden, which we can now measure either by whole exome sequencing or several different commercial assays. Shown here in the upper right, this is the Foundation 1 test, which, as you can see, correlates quite well with whole exome sequencing for tumor mutational burden, as well as neoantigen load, and is equivalent with neoantigen load in predicting response. This is to atezolizumab, and very importantly, is largely non-overlapping with PD-L1. TMB is FDA approved for pembrolizumab in patients with a TMB of greater than or equal to 10 mutations per megabase. But you can see in this particular study, which led to that determination, only selected tumor types were included, and there was no association with response rate or progression-free survival. In addition, TMB seems to be very predictive for checkpoint monotherapy, but as you can see in the 4 analyses, whole exome sequencing, for several pembrolizumab trials, it was not predictive in combination with chemotherapy. Also shown here in checkpoint inhibitor monotherapy, what is commonly seen is a Kaplan-Meier crossover gap, where patients, some patients may have early death with checkpoint monotherapy, not seen in combination with chemotherapy. We first described the analytical and clinical validation of TMB in blood, and this paper is shown here. We used a continuous variable analysis and picked 16 as the level which best described clinical benefit. And you can see, once again, as expected, that those patients with both a high blood TMB and a high PD-L1 fared the best for PFS and OS. But when this was taken into a phase 3 study, this is the BFAST trial recently published in Nature Medicine, the primary endpoint of PFS was not met. This was reflected by the Kaplan-Meier crossover gap, as shown here, since this was monotherapy for atezolizumab versus platinum chemotherapy. And as you can see on the right, it was quite striking that the assay was highly predictive for non-squamous, but totally not predictive in squamous cell lung cancer. So again, PD-L1, TMB, leaving us with an incomplete predictive biomarker. Lastly, these are the 5-year updated survival for the Keynote 189 of pembrolizumab plus chemotherapy in non-squamous. And although you can see a tail on the curve that continues to show an advantage with the checkpoint combination, it is not where we want to be. So are there better biomarkers that are coming along? I think there are. And that leads us back then to the next presentation, which will describe one of those developing biomarkers, Prof.
Thank you, Dr. Gandara, appreciate it. If there are any questions for Dr. Gandara, please put them in the Q&A box and we'll address them at the end of the total presentation. I'd now like to introduce Dr. Ofer Sharon. Dr. Sharon is the CEO of OncoHost. He is a physician and an entrepreneur with over 2 decades of experience in clinical research, pharmaceuticals, and biotechnology. Prior to joining OncoHost, Dr. Sharon served multiple roles in global pharmaceuticals, including AstraZeneca and Merck, and was part of the Keytruda clinical development and launch team. He has co-founded several healthcare companies centered on bioinformatics and machine learning platforms. Dr. Sharon?
Thank you, Chris. Just make sure that, yes, this is working. Perfect. Thank you. So first of all, it's a real honor for me to speak with Professor Carbone and Gandara today. What I'll try to do in the next 10 to 15 minutes is basically describe the platform that we've been developing in the last 4 years, the approach and the way we validate it, and next you will see some of the results presented by Professor Carbone. So let's start with a short description of what we've been working on. The idea of the Prophet platform is basically use proteomic pattern recognition in the patient plasma, combine it with system biology, bioinformatics, and machine learning. And the approach we decided to take when we started the company was we're trying to address concrete clinical questions. What is the clinical question that the oncologist is asking himself or herself on a daily basis, and answer those? And as such, we needed a tool that will support clinical decision-making rather than the classic approach of a companion diagnostic of treat or not to treat, because as Professor Gandara just showed us, this is not the question. The question is how to treat those patients. And this is the approach that we took. In terms of the flow of the product, we require one blood test taken before treatment. We need about 200 microliters of plasma, which are then delivered to a central lab. And then we produce a report that basically includes today 3 elements. The first one, or the first question that we are trying to address, is what is the optimal first-line therapy for the patient? That is followed immediately before that by the result of the test, which may be either positive or negative. We'll describe what that means later. We then provide an analysis, which is based on unsupervised learning of the tumor resistance mechanisms, and then try to associate those with either approved combinations or ongoing clinical trials. If we try to understand where this report, where the Prophet falls into clinical decision-making, everything that we've done until this point is for patients that are driver mutation negative. So we are focusing on those patients that will be treated with immunotherapy first line, whether it's immunotherapy alone, immunotherapy combined with chemo, different options. The cohort on which we developed the algorithm, I think, is a very real-world cohort. The inclusion-exclusion criteria for the clinical trials are very flexible. We try to mimic the real world, the day-to-day of the clinical oncologist as much as possible. And the idea is to support the initial question of how should we start the treatment. So the way we develop the algorithm, we start with creating a very strong, stable predictor of response, but then move from there to a clinical question that is how to start treatment. The test is developed and analyzed in our CLIA certified lab in Cary, North Carolina. We are working in collaboration with SomaLogic. So basically we're using the SomaLogic platform, the SomaScan, is the proteomic panel. The algorithm was actually validated with other proteomic panels as well. I think that we had 3 of those. 2 of them were very good in terms of reproducibility, repeatability, and stability of the platform. And for us, SomaLogic was the chosen one for the clinical development of the product. Here I show you some of the results of the consistency of the different replicates. I think that one of the challenges of dealing with proteins in the plasma are the challenges of measurability, the ability to repeat the results, reproduce the results. We tested for the effects of time on the bench. We tested for the effects of temperature, different operators, different time points. And we managed to get to a point where we are trusting what we see in terms of the ability to repeat and reproduce the result that we are seeing. Next, since we are dealing with machine learning, there are 2 important caveats that we need to take into consideration. The first one is the issue of overfitting. A lot of the algorithms out there, a lot of the machine learning algorithms out there are using techniques that may cause overfitting. The way to avoid overfitting basically is to completely separate the training and validation cohorts. It is an iterative process. I'll show that in the next slide. But once we move into the training of the algorithm, we need to separate the cohorts. So we have one cohort that will be blinded to the R&D team, will be blinded to the algorithm until the day of validation. And all the work that we do is done on the training or development cohort. Once we feel that the algorithm is ready, we basically have one shot at validation. We open the blinded cohort and test the capability of the algorithm to perform what it is supposed to perform. I think that this approach, of course, is challenging and failures are common, but at least when you get the results, you can trust that indeed this is algorithm performance and not an algorithm that was developed for a specific cohort. The second caveat is the issue of false discoveries with machine learning. And that relates to the fact that, again, a lot of companies, investigators are trying to look for very narrow signatures. And when you try to do or work with narrow signatures of proteins in the plasma, you face a lot of challenges. Proteins are highly variable between patients. There are questions about directionability of the protein, whether high protein level means an activity or a low protein level means an activity. And of course, it's very hard to repeat those because when dealing with protein, in many cases, what we have is a snapshot, which is then hard to repeat. So the approach we took is a bit different. We started by identifying proteins that are differentially expressed between responders and non-responders. Of course, if we look at the diagram here on the center panel, we see that some proteins are overlapping, but some proteins are actually different. And these are consistent proteins that we see that are repeating over time. Those proteins were termed as resistance-associated proteins. And then we needed to do, as a next step, we needed to define whether indeed what we see is a signal of an overexpressed protein or just noise. This is part of the work of the mathematical team to identify those proteins, and part, of course, of the IP of the company. And next, instead of looking for a specific narrow signature of a protein, something that we will do in the next stage, at this point, we are just counting the number of overexpressed reps. And what we saw is that patients that have a lot of those reps are not likely to benefit from treatment. And when we are talking about benefit from treatment, we are talking about progression-free survival of over 12 months or below 12 months. Those patients will get a negative report. And patients that have few of those reps, if any, are patients that are more likely to benefit from treatment, and those patients will be the Prophet positive. They will get a Prophet positive report. In terms of the validation plan of the algorithm, as I said, we start with two separated sets of development and validation. We recruit patients in an ongoing prospective clinical trial. And then once we have a large enough cohort, we basically randomly divide the data set to the development and validation, develop the algorithm on the training set or development set, and then run the first validation, which is always blinded. Test the ability of the algorithm to do what it is supposed to do. And once we are done, we are combining cohort and running the validation again. This is called cross-validation and is done on the entire data set. And this approach basically allows us to revalidate what we see and use the algorithm that we've developed in the blinded validation for the positive negative classification. Next, we will be combining the algorithm output, the predictor output, with the PD-L1 level of the patient, and then run a survival analysis. Those results will be presented by Professor Carbone in the next presentation. It is important to note also that everything that we do is based on an ongoing prospective clinical trial. And this is important because it is very tempting to use databases, all databases of patients when you're developing an algorithm. They are more accessible, they are easier, it's quicker. The thing is that when you're doing that, you are risking two things. First of all, standard of care is changing. We are seeing the standard of care evolving pretty quick, and we want to develop the algorithm using the current standard of care. And the second caveat with database-based algorithm development is the fact that in many cases, clinical annotations are questionable. We saw many cases where a patient was termed as responder, and yet we saw a progressive disease when we looked into the files. So in order to avoid that, I think it is very important to run a prospective clinical trial when you are developing the biomarker. That one, and try to make it as diverse as possible. As you can see in our trial, we have sites in Israel, in Europe, in the UK, and in the US, trying to get to a diverse population and not something that is relevant only for one or two sites. This is the design of the clinical trial. This is an ongoing trial. We are still recruiting patients. Basically, we recruit the patients. We take one blood sample before treatment. In some of the sites, we collect longitudinal, but those results are not ready for presentation yet, longitudinal samples. We then assess for response at 3 months, 6 months, 12 months, and follow up on patients for up to 2 years. And now we are amending this protocol to increase the follow-up to up to 5 years. So proteomics data is coming from the blood test, and then the clinical benefit labeling, as well as the clinical characteristics of the patients, are coming from the sites. We identify the reps, we identify the proteins, train the model on those, create a predictor, score is given for each one of those reps, and then we are combining the score to the either profit negative or positive, including the profit score that appears on the report. With that, I will end and hand over to Professor Carbone to discuss the next presentation.
Thank you very much, Dr. Sharon. Now I'd like to introduce Dr. David Carbone. Dr. Carbone is a professor of medicine and director of the James Thoracic Oncology Center at The Ohio State University, Wexner Medical Center. His research interests have been focused on lung cancer and specifically proteomic and expression signature development, lung cancer genetics, tumor-associated immunosuppression mechanisms, proteomic profiling of lung cancers to guide the development of novel therapeutics and targeting novel immunosuppression mechanisms. He has over 250 peer-reviewed publications and is also a past president of the International Association of the Study of Lung Cancer. Dr. Carbone, thank you very much, and I'll hand it over to you.
Well, great. It's a pleasure to be here and talk about the profit validation and clinical utility data. These are my disclosures. So what I'm going to discuss is their patient cohort of 585 lung cancer patients. There were 272 in the validation cohort and 228 in the development cohort. 500 patients were treated with anti-PD-L1 or PD-1 plus or minus chemo, and 85 were treated with chemotherapy alone. There were 272 naive first-line patients treated with anti-PD-1 uses a blinded validation cohort. 85 patients first-line treated with chemotherapy used as a chemotherapy control. You can see the clinical characteristics of these patients where in the ICI cohort, pretty much balanced by sex. There were 47% of the patients PD-L1 high, 80% non-squamous, 40% received checkpoints alone, and 59% received checkpoint plus chemotherapy. Very small number of never smokers. Most were smokers or ex-smokers. And about 30% of these had clinical benefit. And these are the data for the various metastatic sites. So applying this profit predictor to the blinded validation cohort generated these data. And on the left, you can see a novel way to depict the accuracy of a test like this. And this takes a little bit of thinking to see how they did this, but the test predicts a clinical benefit probability. And if you array the patients in order of their predicted clinical benefit, and then use a window, a sliding window of 10 patients throughout this range, and take the average, or take the fraction of those patients who benefited within that window to generate a point. So if down here you had 10 patients in the group and 1 had clinical benefit, up here you had 10 patients and 5 had clinical benefit. And if you analyze the data in this way, you have a remarkable tight correlation between predicted clinical benefit probability and the observed clinical benefit rate, with a highly statistically significant R squared value. And this is the predicted clinical benefit at 12 months. And if you look in the entire validation set at the overall survival of profit positive versus profit negative, you can see a very distinct separation of the curves, with a median survival in positive patients of 26 months and negative patients of almost 11 months. And this just shows the number of patients at risk and quite a mature data set. Hazard ratio of 0.51, highly statistically significant. So then if you look in various subsets, this is the PD-L1 greater than 50% subset that were profit positive and treated with either ICI plus chemotherapy or ICI monotherapy. And you can show that whether these patients got treated with IO monotherapy or IO chemo, the profit positive patients did quite well, with a 27.2-month median and a 32-month median. However, in the same high PD-L1 subgroup, profit negative patients had a distinct split, where the ICI chemo patients did significantly better than the ICI monotherapy patients, as shown in this figure. So there was no statistical difference in profit positive patients between IO monotherapy and IO chemo, but in profit negative, there was a statistical significance. Now, in the difficult subset of patients with a PD-L1 between 1 and 49, this shows the data for the ICI chemo group, an ICO monotherapy group, and the chemotherapy alone group. So if you had this intermediate PD-L1 positivity and were profit positive, the ICI chemo group clearly outperformed the chemotherapy group, but really was similar to the ICI monotherapy group. And in this situation, the overall survival was significantly longer in patients treated with ICI chemo compared to chemo, and a good outcome in the anti-PD-1 treatment group. So with profit negative patients, though, in the PD-L1 intermediate group, really none of the groups stood out as having a very good benefit. And you can see in this group, the ICI chemo median OS was 11.5 months compared to the profit positive group, which is 27.9 months. The ICI monotherapy group here was only 9 months compared to 15 months in the profit positive patients. And this was the comparison of ICI chemo and ICI mono was not statistically significant. So now in the PD-L1 negative patients, this compares the PD-1 plus chemotherapy to chemotherapy alone. So if you were PD-L1 negative but had profit positive result, there was a hazard ratio of 0.41 for ICI chemo versus chemotherapy. The median survival of 23.2 months, very comparable to the higher PD-L1 groups. But in profit negative patients with a low PD-L1, the curves are very similar, with really no difference in the median survival and no statistical significance in the Kaplan-Meier curves. So in summary, the overall survival was significantly longer in patients with anti-PD-1 plus chemo compared to chemo monotherapy in the Prophet positive group. And there was a good typical outcome for anti-PD-1 plus chemo in this population, the Prophet positive population. But in the Prophet negative, no significant difference in survival was seen between the groups, with a poor outcome for anti-PD-1 plus chemo, a median overall survival of 7.5 months compared to 6.7 months in the chemo-only group. Now, the real test of a biomarker is what we call an interaction p-value, or an interaction test. And this table looks at the interaction test of the Prophet with treatment. And this interaction test showed that the interaction between the Prophet classifier and treatment was found to be significant for patients with PD-L1 greater than 50%, with a p-value of 0.03. And the interaction between treatment and all of these other clinical factors was insignificant. So is this test predictive or prognostic? Again, this is the curve we saw in the beginning, with a tight correlation between observed clinical benefit and Prophet predicted clinical benefit in the ICI treated patients, with a hazard ratio of 0.51, highly statistically significant. But if you look at the comparison of the positive versus negative patients in the chemotherapy cohort, there's a very unimpressive correlation of clinical benefit with the prediction, and no statistical significance in the Kaplan-Meier curves. So this suggests that the model is predictive for response to PD-1 inhibitors, and possibly weakly prognostic, but highly statistically significantly predictive. So what we're discussing today is a further subclassification of non-small cell patients, not just into the NCCN groups of PD-L1 greater than 50% or less than 50%, but rather subdividing the greater than 50s, the 1 to 49s, and the less than 1s into Prophet positive and Prophet negative, with distinctly different outcomes for different types of treatment. So in summary, this is a very impressive independent validation of this Prophet classifier in a new cohort of 272 patients, supporting the original study conclusions. And in particular, if you have a PD-L1 high patient, the Prophet positive group follows similar OS statistics when treated with PD-1 inhibitors with or without chemotherapy, suggesting in this population you could spare the patients the chemotherapy. Prophet negative group in the PD-L1 highs really had a significant OS benefit with PD-1 inhibitors in combination with chemotherapy, and not as good with IO monotherapy. In the PD-L1 negative patients, the Prophet positive patients, PD-L1 less than 50% patients, the Prophet positive group benefited significantly from treatment with PD-1 inhibitors plus chemo, whereas for the Prophet negative group, the outcome was typically poor. And for patients with PD-L1 less than 1%, the observed benefit of PD-1 inhibitors in the Prophet negative group compared in the PD-1 inhibitors plus chemo to chemo as monotherapy was statistically insignificant. So the model predictive capabilities for anti-PD-1 based treatment is superior to chemotherapy based treatment, suggesting the model is predictive and not prognostic. And the proposed conclusions remain statistically significant after multivariate analysis. So I like to think of biomarkers for immunotherapy kind of in this way, that if you have a targeted therapy, you have a single biomarker that determines whether you pick one TKI versus another. But the immune system is way more complicated than having a single activated driver. There are multiple regulatory pathways, and it makes sense that predictive biomarkers for immunotherapy will be complex and multifactorial, like this one. So I think now we proceed to questions.
Well, thank you, David. Chris has some questions for us. I think there's also several points that I would like to come back to and discuss. So, Chris, do you want to start with the question?
Yeah, let me start with the questions, and then you can ask of each other as well. So first, for Dr. Sharon, are you able to describe how the candidate biomarker proteins were selected initially as part one? Did you use shotgun proteomics? And then second, what was the reason to choose SomaLogic over other technologies? Which assessments were done? You're still on mute, actually. Hold on, Yannick.
Yeah, I think I fixed it. Can you hear me now?
Yep.
It's after all it's Zoom. So let's start with the first question, and that is the question about the choice of proteins. This is a work in progress for the last 4 years, and the way we try to approach the proteins question is by trying to divide or look at the resistance mechanisms. We are specifically focusing on 5 of those. Inflammation, immune modulation, metabolism, angiogenesis, and proliferation. And under those 5 mechanisms, which are currently are the target of about 95% of all ongoing clinical trials, we try to identify the relevant proteins and, more importantly, the relevant signaling pathways. And when we looked at the different platforms that we can use in order to basically measure the proteins, we had the choice whether we go for something like mass spec, which was not a good enough tool for us because of issues of dynamic variability. And then some others. I mentioned 3 companies that we work with. One of the companies, I won't mention the name, did not qualify in terms of the required quality of the test and ability to repeat and reproduce the results. 2 companies were really excellent. One was SomaLogic, and the other one was owning 2 very stable, good platforms. Some downsides to each, but good platforms. The decision to move forward with SomaLogic related more to commercial terms than anything else. They do have some advantage in terms of the number of proteins that they screen for, which was something that was nice to have. But the weight of the decision came from the commercial terms. So I think 2 excellent platforms to work with. Other companies that we have in the market today that are developing proteomic panels are also very interesting. I think that the issue there is still the relatively low number of proteins that we can get from those platforms. But this is something that we definitely intend to look into in the future.
Very good, thank you. We have multiple questions now coming, which is nice. Dr. Carbone.
This second question about prediction for second-line therapy, we might hold, since Dr. Sharon actually has some slides that might be relevant there. And I can see that's probably what you were going to do.
Okay, so the second line, yes, we can hold on that. One question is, have you analyzed profit prediction response in non-squamous only, since squamous does not seem to respond as well to ICI? That's directed to Dr. Carbone, but Dr. Sharon could also help on that as well.
I think that would, we didn't present data on that, so maybe Dr. Sharon could help us with those subsets.
Yes, so am I? Yeah,
yeah, you're good.
Yeah, I'm good. Can you repeat the question, Chris, about
yes.
Have
you guys has there been any analysis in in squamous, since they don't seem to respond as well? So what data do you have?
Squamous versus non-squamous.
Yeah,
squamous versus non. Yes, we have the analysis. The numbers are not big enough. We do see that the squamous patients are not responding as well, obviously. but we don't have a clear differentiator. So the algorithm currently doesn't have the ability to differentiate between those two histologies. It may be a matter of number of patients at this stage. We don't know yet, but this is an analysis that we are running and will continue to run as part of the subgroup analysis. So currently, we don't have any data for that.
Okay. So a question for Dr.
Also that squamous patients, of course, do respond to checkpoint immunotherapy and do have improved survival. But as I showed in the initial unmet need slides, PD-L1 prediction and TMB, the two most common biomarkers we use, are not as useful in squamous cell lung cancer, therefore the unmet need.
Very good. And I think this next question could be for Dr. Carbone and Gandara, maybe both opinions. So going back to the PD-L1 patient that's greater than 50 and also Prophet positive, where monotherapy was the choice for that patient, would you consider chemotherapy in that patient if the patient was symptomatic? Or would you use monotherapy given the results?
Well, a lot of lung cancer patients are symptomatic, and I've treated many symptomatic patients that are high PD-L1 with IO monotherapy. But having this test might give me a little more confidence if the patient was Prophet positive.
And I agree with Dr. Carbone. Of course, I think the most useful aspects of this test are in the categories of patients where we really have difficulty, and in particular, the data where Prophet is negative, or I should say rather where PD-L1 is negative, meaning not a single cell staining, and yet the Prophet positive patients fare well. That's the category of patients which I think is the most impressive aspect. But it's all the data are impressive to me. It's still small numbers, but this is quite a remarkable achievement.
I would still like to see something that I haven't seen so far, is a study that prospectively tests two cohorts of patients, one whose treatment is determined by the test, and the other one in a randomized fashion receives investigator choice therapy. And I would very much like to see whether knowledge of the biomarker improves survival of the group.
Yes, this trial is actually under design right now. The protocol is almost ready, but this is the ultimate outcome trial for us, of course, showing that we can actually improve outcomes based on the choice of or the classification of the Prophet. In design hasn't
actually reduce toxicity and then use of chemotherapy in patients who don't need.
Very good. I think you answered another question here already with the longitudinal assessment of Prophet, how it changes, how its change affects treatment strategy. And I think you've all discussed that a little bit. If you want to expand more on that. I don't think
we really talked about serial assessment of Prophet.
Yes.
Okay.
And how it changes between first and second line therapy, or in the chemo only patients, whether it changes before and after chemo and predicts second line therapy. That's an interesting question. But what was presented was really pre-treatment Prophet values in first line patients.
Okay.
There is an interesting question here, Chris, about so-called non-shedders. So we know for ctDNA that some patients, particularly those with low volume disease, don't put much of the DNA into their blood to be assessed. And the question, Dr. Sharon, was for Prophet, or do there seem to be patients that don't have the appropriate proteomic markers in their blood, or is it a way to quantitate to know, is there a threshold level?
Yes, so definitely I can tell you that we identified RAPs, resistance-associated proteins, for all of the patients, even the responders, those that benefit from treatment. And of course, the issue was to identify the threshold above which you define a patient as a patient that will not benefit from treatment. What we saw that we really liked when we assessed for the number of RAPs is that the AUC, the area under the curve, was not a very sharp one. The curve was very nicely round, which means that we can that we have a range of a threshold, a number of reps that we can use. I think that the lowest number of reps that we've identified in patients was 1. So 1 protein that were overly expressed, but we saw no patients that had nothing. There's always some resistance mechanism active, even in the highly responding patients.
Okay. Is there any data on anti-CTLA-4 combined with Pembro? Any research done?
Or
Yes,
maybe
so-
Nivo would be better.
Yeah. So we have some so the cohort is not big for the Ipi-Nivo, and it's not big enough for comparison between different anti-PD, PD-L1 drugs. We do have some initial results. I don't think that we can trust them enough to present them at this stage. So I do want to increase the cohort. Specifically for the Ipi-Nivo combination, we tried to run an analysis because this is, of course, a very interesting question. But the patients' overall survival in the cohort that we do have was very, very low. Patients died very rapidly. I think this is an issue of more than anything of a selection bias. These patients were chosen for the treatment probably because of their situation in the early days of this approval. This is a cohort of interest, and we are trying to work with BMS actually to see if we can run an analysis for the Ipi-Nivo cohort separately. Currently, we have some results, but I don't think they tell us the big story yet.
I can add, speaking on behalf of the Lung Master Protocol, LungMap, that Dr. Sharon presented these data to our TM committee. We have a phase 3 trial, the S1400I, that compared Nivo-Ipi to Nivo. And I think that would be an interesting cohort to analyze by this mechanism.
Very good.
So there's another
ethnic-
question about the ethnic association and regional associations, and your samples come from different parts of the world. Did you look for systematic differences in the different populations from the different parts of the world?
We did. We don't have data coming from the Asia Pacific region. Only from the Israel, Europe, and the US. With good ethnic variability, we saw no differences. With that said, we have to remind everyone that we don't have data for patients that have driver mutations. All of the data is for driver mutation negative patients. This is a cohort that we are, patients with EGFR mutation is a cohort that we are just now starting to analyze separately.
We're not going to get to the other slides, so we can address it. What development are you currently doing in second-line therapy?
So first of all, yes, this is something I wanted to get back to. In the current ongoing clinical trial, we have longitudinal samples. In some of the centers, we have more than the pre-treatment. We have samples that were taken every 3 months. And we are starting to develop a monitoring predictor that will allow us to identify patients with potentially acquired resistance, very early days. We recently announced a collaboration with Baylor Scott & White and TGen that was announced about a month ago. This is an ongoing longitudinal trial with serial assessments of proteomics, cell-free DNA, single cell analysis, PBMCs, and microbiome in the metastatic adjuvant and neoadjuvant setting. This trial will look at cancer-resistant dynamics over time, and there will be also, I forgot to mention, correlation to tissue whenever possible. Plasma proteomics with what we see in the tissue. So this trial just started. We have already a nice cohort of patients there, but analysis is still pending.
Okay, is the Prophet test currently available in the US?
Yes, it is. For the metastatic setting in non-small cell lung cancer, we have the first product that was launched about I don't know, 4 to 6 weeks ago, and is available for the rest of the indication, the setting only via the clinical trial. So we are now recruiting patients also with melanoma, small cell, and soon we're going to add RCC and head and neck.
Okay. I think we have time for another total plasma or exosome. How is this gathered?
This is total plasma.
Total plasma, okay. Any correlation with TMB and profit? Has that been looked at?
Yes, we looked at it, we saw no correlation.
Okay. All right, I believe that wraps up the Q&A. So if there was nothing else, does the test work in other solid tumors? One last question.
The answer is yes. We are not showing results yet. The result is published soon, but we have cohorts in melanoma, in small cell, and we're soon going to start other solid tumors.
Okay, very good. Well, again, thank you very much. Any closing comments from any of the speakers? If not, I'll close it out.
David Gandara here. I just want to thank everyone who has joined us and also who will be seeing this webinar virtually. It will be on our ISLB website for a number of months as well, for those that might want to go revisit it. This is our first ISLB webinar of the year. We want to thank OncoHost and also ICS, who is working with us on these productions. And I just want to give my thanks to everyone involved.
Thank you.
Thank you, Dr. Gandara. Thank you, Dr. Carbone and Dr. Sharon. Excellent webinar. To everybody else, have a pleasant rest of your evening.
Thank you.
Hi, I'm Anna, a board-certified nurse practitioner and director of clinical oncology at OncoHost. Today, I'm going to tell you about OncoHost's Prophet platform and how the report it generates can support clinical decision-making, saving valuable time and helping to better optimize cancer treatment planning for each individual patient. Nowadays, treatment protocols are based on a one-size-fits-all approach. The lack of biomarkers for immunotherapy is making it difficult to identify patients who will benefit from a specific therapy or a combination of therapies, which can be very effective and safe for some patients, but ineffective or even harmful to others. Unfortunately, in many cases of advanced cancer, clinicians struggle to find reliable biomarkers to guide their complex decision-making process. At OncoHost, we have developed a precision oncology solution to solve this problem and enable true personalized treatment for cancer patients. Prophet, a first-of-its-kind diagnostics platform, analyzes proteomic patterns in a patient's plasma, characterizing the complex interplay between the tumor, the patient, and the therapy. This technology was developed at the Israeli Institute of Technology after decades of research. Our first test was developed for non-small cell lung cancer. With one pre-treatment blood test, Prophet provides a report answering an important clinical question. What is the optimal first-line treatment for this patient? The personalized report sections include the Prophet result, which will be either positive or negative and is a measure of the predicted clinical benefit of the patient. Treatment considerations for this patient based on their Prophet result, combined with their PD-L1 status and the clinical evidence that supports the Prophet result. Prophet is validated by a large-scale prospective clinical trial with over 40 sites worldwide, including in the US, EU, UK, and Israel, with over 1,400 patients enrolled to date. Our results have been presented at multiple conferences as well as published in peer-reviewed journals and abstracts. We are also partnered with large academic institutions worldwide. OncoHost technology and approach offers the potential to identify the right treatment for each individual patient with just one simple pre-treatment blood test. With Prophet, patients and physicians can benefit from personalized early response prediction and identification of potential targets to improve response rates and ultimately survival outcomes. We are now empowered with a new dimension of information to support the complex decision-making that clinicians face in the management of advanced cancer. Together, we are providing better, more personalized patient care and rewriting the future of precision oncology. To learn more, visit www.oncohost.com.